Good evening, everyone. I'm Dr. Monica from Shield Healthcare. I welcome you all for today's session, TNFOG Marathon CME on Anemia in Pregnancy. And I welcome Dr. S. Sampath Kumari Ma'am, MD, DGO, FICOG, FCDIA, FIME, and she's a professor and HOD obstetrics in Sri Muthukumaran Medical College Hospital, and she's a Foxy Vice President 2022, Senate member Tamil Nadu Dr. MGR Medical University, and National Corresponding Editor Journal OG of India, and Founder Secretary Tamil Nadu Federation of OBGYN TNFOG, and retired Deputy Director Institute of OBS Gynae MMC Chennai. President Board of Studies OG Tamil Nadu Dr. MGR Medical University 2015 to 19, Chairperson Foxy Adolescent Health Committee 2016 to 18, first ICOG Distinguished GC Member Award 2001, Chairman Women's Wing IMA Chennai South, IMA National President's Award and IMA TNSB Award 2001. I welcome you, ma'am, for today's session.
Thank you. So I welcome everyone, the Chief Guest Dr. Alka Kriplani, Guest of Honor Alka Pandey, and our President Dr. Revathi Janakiraman, and all the speakers and the panelists and moderators and the coordinators for the CME. This Marathon CME is organized by the Tamil Nadu Federation of Obstetrics and Gynecological Societies on every second Friday of every month. But due to some administration problem, today we are having on Thursday. This Marathon CME, we have two sessions. The first session being the juniors, Yuva will give the talk and two judges will be there. So after the end of the year, the best speaker of the Yuva will be selected. The judges will be the same for throughout the year. And the second session being for the seniors and the panel. After the each session, we have question answer, which has to be answered only by the delegate or not the faculties. The prizes will be given for the delegates. So this is the reason we have called it as Marathon CME. This is our second Marathon CME of this year. The topic, the common topic being the anemia in pregnancy, which is followed by the Women's Day. Of all of us know that about 60 to 70% of anemia is common in pregnancy, and even in adolescent, anemia is very common. That is the reason we have taken anemia in pregnancy as the topic. Now I will hand over the mic to our MOC, Dr. Priya Kannappan, to take over the session.
Thank you, madam. Thank you. So can we go to the next slide, please?
Priya, 1 minute. Priya Kannappan is the active member of OG Chennai Society, and she has done her MSOG and MSCOG. And she is the EC member of a quiz committee of the Foxy. Priya Kannappan, back to you.
Thank you, madam. Thank you. Thank you for such a kind introduction. It's always a pleasure to come back to work with Sampath madam, and now we have our other president, Dr. Revathi madam. So it's very nice, when coming back to TNFOG, it's like coming back home. So it's nice feeling we have. So I would request all the dignitaries to raise up for the Tamil Thai Valtu. Thank you. And we all know that no function can start without the lighting of the Kutuvilaka. Yes. So I would invite all the faculties and the delegates to come and participate in the lighting of the Kutuvilaka. So with the brightness of this Jyoti, so we'll go to the next slide. So this CME is going to give you loads of information about anemia, and you'll be like, bright as the light which is there. So I would request our President Madam, Dr. Revati Madam, to give the welcome address to the audience. Madam is the professor, former director, IoT Chennai. She's a Vice President, Foxy South Zone 2016, President of TNFOG in 2023. Madam is a Founder Secretary, Past President, Madurai OG Society, and Madam is a Founder President of IMS Madurai. And she's been like in many posts there, and a Lifetime Achievement Award from the IMA Madurai. And Madam has been authored in many of the articles and the Pride of Foxy Award in November 2019. Over to you, Madam.
Thank you, Dr. Priya, for your kind words. It's my pleasure to welcome you all to this very important CME on anemia in pregnancy. You know, the reason, in spite of so many works being done by us, the incidence of anemia in pregnancy has not shown any significant reduction. And therefore, we need to focus more and more on that and how to manage it and practically bring it to zero, the incidence of anemia in pregnancy. It's my pleasure to welcome the chief guest, Dr. Alka Kriplani, and guest of honor, Dr. Alka Pandey. With both Dr. Alkas, I have been very close, and with Dr. Alka Kriplani as president, I have been working as vice president. And at that time, Dr. Alka Pandey was under me looking after as chairperson, Safe Motherhood Committee. And I also welcome the evergreen judges, Dr. Nidhi Sharma and Vijay Lakshmi Kandasamy, and the Yuva participants, Dr. Krishna Parvati and Dr. Selvarani. I'm happy to know that Selvarani is Yuva. And I also welcome Chairperson Dr. Ramni Devi and faculties Dr. Shanti Gunasingh, panel moderators Dr. Sivakami, Dr. and all the panelists. And I am sure all of you will concentrate and identify where exactly we are lagging in managing the anemia in pregnancy, and let us work hard to totally eradicate anemia in pregnancy, thereby improve the maternal mortality. By reduction of maternal mortality, this is one important area which we have to concentrate on. And I'm sure at the end of this session, we'll be carrying a lot of take-home messages, which you can use it practically to eradicate anemia. Thank you very much.
Thank you, Madam. That was so short and crisp. And whatever the points need to be told, you have enlightened us very well. So thank you for the words, Madam. So can we wait? Can we release the newsletter after the chief guest arrives, Madam, or should I go ahead? Sambat, Madam, Revati, Madam.
Priya, you can go ahead.
Okay, Madam. So in this occasion, we will be very happy and proud to release the newsletter of the TNFOG. So now I would invite our President, Madam, and Dr. Ramni Devi, Madam, to come and release the newsletter. And Dr. Sambat, Madam, our Founder Secretary.
Yes. We'll release that.
Yes.
Start.
Chitrakala powder.
She started.
Yes. Thank you.
Thank you. We will move on to the next session. Priya?
Yes.
Congratulations once again, Revati Madam and Sampat Madam, for bringing about this e-newsletters regularly. Yeah.
Thank
Alka
you.
Kripalani
Thank
madam is
you.
coming online. Madam, you have to join the session, madam. We are waiting for you. I have sent you the link, madam. I have sent you, see, in your WhatsApp. Okay. Alka madam is coming in a minute.
Okay.
Huh? I think she was in a surgery. She's calling.
Okay.
Hmm.
Dr. Alka Kripalani?
Priya?
Yes, ma'am. Chitra here, ma'am.
Chitra, Selvarani is not able to share her PPT. Kindly, get the PPT and share it for her, no, please.
Sure, ma'am.
Selvarani,
Selvarani, ma'am, you can share to me, ma'am. I got the PPT, ma'am.
I'll send the PPT in the group, ma'am.
Sure, ma'am.
Group you have sent. No, don't worry. Then she will share, ma. Don't worry. If you
Yes,
send it in
ma'am.
the group,
Thank
they will
you.
share. Don't worry. Yeah.
Thank you, ma'am.
Alka madam is joined, madam.
Can't see her.
Yes, ma'am. Not yet, ma'am.
You have to see. She's got the link, no?
I have sent it, madam.
Ah.
Where is the link? Before that also.
Ma'am, joined, ma'am.
Okay.
Hi.
Hello, Alka madam. Good evening.
Good evening, Dr. Alka ma'am.
Sorry, I'm still in the theater. I just got out of place.
We are all waiting for you only. We are waiting for you only.
Can we have Madam CV?
Yeah.
Revati madam, can you introduce that?
It's my great pleasure to introduce Dr. Alka Kripalani, who is the director and head of the department of ART Paras Hospital, Gurgaon. She was president of FOXI 2016 when I was the vice president. Madam, we had a very nice time at that period. President Jesse, President DGES, President AOGD, and co-chair FIGO Menstrual Disorder Committee in 2016 and 18. And she has a lot of awards to her credit, around 50 awards, including Padma Shri Award, BC National Award, Honorary FRCOG, IMA Med Achievers Award, Times Healthcare Award, Achievers Award, and so many things. And she has given a lot of orations and done a lot of live workshops. Also, I think cadaver workshop also she did once. And she is a pioneer in laparoscopic surgery. And still she continues to be, even here now she is coming midway between the surgery only. It's my pleasure to welcome you, ma'am, and say a few words blessing us this program. Over to you. Please unmute yourself, Dr. Alka. Please unmute yourself.
I have done that.
Yeah.
Fine.
A very good evening. It's such a great pleasure to see my Vice President Revati, who did wonderful work with me in my, and she is such a great worker, grassroots worker. She organized so many, and this anemia, I'm so happy today that you people have, and what to say of Ramani? Ramani, you got some big research award, no? So hearty congratulations.
Thank you,
Very
madam.
well deserved.
Thank you, madam.
And I really respect you professionally so much, Ramani. You are so sincere. And being in practice, people are such academic, research-minded. Salute to these heroines from the South. medical heroines. And what to say of anemia? I have come in practice and I am in such a nice city of Gurgaon, and I see 60 to 70% of girls of all ages suffering from anemia. I really don't know why we are working for so many years, nothing is happening. I think the injectable iron is a very good way to take care and reduce blood transfusion. And we have to do more and more awareness programs. I think Indian diet has problem, I fight it. I think this menstruation, and we are already on the verge of, anemia, because our nutrition is on borderline. Even in good families, healthy diet is lacking. Maybe there are more of these worm infestations, and chronic infections. Whatever are the reasons, this rampant anemia, and Ramini and Reti and all of us have to still work for decades to remove this problem of anemia, which is such a simple solution. You give iron, never give iron without vitamin C and B12 and folic acid, otherwise they develop into hypochromic. So give all the nutrients or give injectable iron, they become 12, but again in 3-6 months they are back to. I think the basic reason is the faulty diet, faulty absorption, malabsorption. And let us see what these wise medical heroines from the South, whom we all really respect for their hard work, what they have to teach us today on anemia. And we should keep banging on everybody's head. Maybe it's a patient, maybe patient's husband, maybe her mother-in-law, maybe our doctor colleagues. Beware of anemia, take care of anemia, because it is a very big health hazard, especially in pregnant patients and especially in AUB patients. We are facing 60 to 70% incidence of anemia, and we wish you people all the best. And thank you for the invitation. And I'm sorry I joined little late. I'm still in the theater, but Ramni and Revti's invitation, who can refuse? So wish you all the best for this wonderful deliberation. Thank you for the invitation.
Thank you.
Thank you, madam. Thank you.
Dr. Sampath Kumari is our vibrant secretary of TNFOG.
Oh, I'm so sorry, Sampath, and I got phone calls from you. And now I will remember Sampath Kumari, because whenever Ramni talks to me, she reminds me of Sampath Kumari.
Thank you. Thank you for your kindness. Priya?
Thank you, madam. Thank you. That was such a lovely words from you, and seniors like you are there to guide the juniors like us. So we are like, next we'll go to the Yuva session. We have our Yuvas, they are going to come and present to us the cases. So I'm going to invite the judges for our session. Dr. Nidhi Sharma, she's a professor of Obs and Gyn in Savita Medical College and University. Madam has done her MBBS and MS from Banaras Hindu University, Varanasi. She's done a fellowship in Indian College of Obs and Gyn.
Thanks, Priya. We'll start calling the UAs now. Okay.
Madam, at least one thing I want to say, like you have more than 100 indexed national and international publications, and you have done a PhD as well. So madam will be the best person to think of judge for any paper. So next judge for today will be Dr. Vijayalakshmi Kandasamy madam. She's a professor of Chettinad Medical College and University. Madam has done many achievements and prizes, and she has presented so many papers, and she's been a judge in many conferences for the paper poster presentation. So she'll be like, there is nobody to compete with these two judges. So now over to you, madam, to welcome the US.
Yeah, it's my proud privilege to welcome Dr. S. Krishna Parvati. She did her MBBS from Marpuda Vida Medical College, Puducherry, Vinayaka Missions University, 2005-2011. She then did her master's in obstetrics and gynecology from Government Medical College, Tirunelveli. Her career interests are being an infertility specialist, doing vaginal surgeries, and she also carries an interest for laparoscopy and endogynic procedures. She has achievements of gold medal in anatomy, biochemistry, and surgery that is really creditable. Dr. Krishna was ranked university second in MBBS final examination. So Dr. Krishna, we'll welcome you to start your presentation.
You have to unmute yourself. Dr. Krishna, please unmute yourself.
Yes.
Yes.
Thank you, ma'am, for your kind words.
Can you screen share? Yes. Yeah. No, the next one. Yeah.
Good evening. Today my topic is iron metabolism in pregnancy. Introduction. Anemia is the most common hematological disorder in pregnancy. It is also a major public health concern in developing countries. Prevalence. Anemia affects nearly 50% of pregnant women globally. Compared with 25% in developed countries, the prevalence of anemia in Indian mothers is between 80 and 90%, roughly about 87%. Definition. Anemia is defined by the World Health Organization as hemoglobin levels less than or equal to 11 gram per deciliter or a hematocrit value of less than 33%. FOGSI has suggested a cutoff of 10 gram per deciliter for India. ICMR has also defined anemia. The mild category is between 10 to 10.9 gram percentage, moderate lies between 7 to 10 gram percentage, severe is less than 7 gram percentage, and very severe is less than 4 gram percentage. Iron metabolism. Before going on to the iron metabolism in pregnancy, I would first like to throw some light on iron metabolism in non-pregnant women, that is in normal human beings. Iron metabolism, it varies in pregnant and non-pregnant women. There is an increased demand for iron in pregnancy to supply the fetus and placenta, in addition to supporting the increase in mother's blood volume. The body's iron stores also have to be supplemented in anticipation of the blood loss during delivery and the postpartum period. Pregnancy causes important changes in iron metabolism to meet these demands. Now, how does our body uses iron? The iron is absorbed, it is lost, there is functional iron, and there is also storage iron. Now, how is the iron absorbed? The iron is absorbed mainly in the duodenum. 10% is normally absorbed. In iron deficiency anemia and growing children, the absorption is more lost. The total amount lost is roughly about 0.1%, that is 1 to 1.5 milligram. The rate is double in case of females simply because they are menstruating. From the gut and skin, about 0.2 milligram is lost. From the urine, 0.1 milligram. And from the menstruation, that is roughly about 30 milligram per period is lost. Functional iron. Hemoglobin is a main functional iron. It is an auto-carrying protein. It accounts for 70 to 80%. Myoglobin, the muscular protein, 2 to 3%. And iron enzymes, which are the catalase, peroxidase, cytochrome, tryptophan, pyrrolase. Iron is the most important mineral which is involved in the energy synthesis pathway, which is involved in electron transport chain and also in oxidative phosphorylation. Storage, 30% of the iron is stored mainly in the reticuloendothelial system, which comprises of the spleen, bone marrow. It is stored as ferritin and hemosiderin. Dietary iron. The normal daily diet contains 10 to 20 milligram of iron, but only 10 to 15% of the iron is absorbed. So it is absorbed only 1 to 2 milligram. Iron is mostly found in foods in the ferric form, which is bound to proteins or organic acids. Reducing substances reduce the ferric ion to the ferrous ion. Iron in the ferrous form is soluble and it is readily absorbed. The heme iron, which is a non-vegetarian diet, which is present in the non-vegetarian diet, or it is a muscle protein, it is better absorbed, but it forms only a smaller fraction of the diet. Whereas non-heme iron, which is found in mainly in the vegetarian diet, is an inorganic iron, and it is mostly present in the ferric form. It has to be reduced to the ferrous form before absorption can take place. Factors increasing the iron absorption are acidity, ascorbic acid, cystine. In iron deficiency anemia, the absorption is 2 to 10 times increased when compared to normal. There are small peptides and amino acids. Meat increases the HCl secretion and thereby facilitates the iron absorption. Absorption of heme iron is 2 to 3 times more than non-heme iron. That is, from the non-vegetarian diet, the absorption is more compared to the vegetarian diet. Factors decreasing the iron absorption are phytates and oxalates. Phytates are mainly present in the cereals. Our staple food is the cereals. So naturally in Indian diet, the iron absorption is reduced. Diet with high phosphates, tea, egg, copper deficiency, malabsorption syndrome, administration of alkali, partial or total gastrectomy, and calcium salts. So even though with the diet, iron is getting absorbed from the duodenum, patients who have total or partial gastrectomy also have difficulty in iron absorption. So now this is the overview of iron metabolism in non-pregnant women. Learning iron metabolism is very important because iron is a very important mineral which plays an important part in our for the metabolism, whereas excess iron is also toxic. So iron metabolism has to be very tight. Now this picture shows The erythrocyte, ferritin, which is blue circle, ferric iron, ferrous iron, transferrin. Please note the symbols that are given on the side of the screen. So now from the duodenum, from the diet, the iron is taken inside the duodenum, from where the iron is transported into the blood circulation by that is ferric iron, that is Fe3+. It combines with the transferrin, plasma transferrin. So the Fe3+ plasma transferrin complex enters the blood circulation. Iron that is taken from the diet passes from the duodenum into the blood circulation as Fe3+ combined with the plasma transferrin. That is the green diamond inside which the blue color square is present. That is ferric iron and transferrin complex. This ferric iron and transferrin complex from the blood circulation enters the liver, where it is stored as in the form of ferritin. And again, the ferric and the transferrin complex enters the bone marrow, where it is used for erythrocyte generation, that is erythropoiesis. And the released RBCs which enter the circulation eventually has to meet their fate after a span of 120 days. So they go into the reticuloendothelial system, which is the spleen, where they are recycled, and again they enter into the circulation as Fe3+ transferrin. Excess iron is also stored in the spleen in the form of ferritin. The storage form of iron is mainly plasma ferritin. So ferritin is a sensitive indicator of iron stores. So in case of iron deficiency anemia, we measure plasma ferritin. Decreased plasma ferritin implies decreased iron stores. So this is the regulation of iron absorption. This is the picture showing the duodenal cell, introcyte. So this is the apical brush border site, and this is the basolateral site. And in the apical brush border site, we have a heme transporter, that is heme carrier protein 1. We have a duodenal cytochrome B, and we have a DMT1, that is divalent metal transporter 1. So the food iron, which is the heme iron, and the non-heme iron. The heme iron is directly entering into the duodenum by means of the heme transporter, that is the heme carrier protein 1, whereas the non-heme iron is present in the ferric form. This ferric form has to be reduced to ferrous form in order to enter the duodenal enterocyte. This reduction takes place with the help of duodenal cytochrome B, which reduces Fe3+ to Fe2+. Now, this ferrous form enters the duodenal enterocyte by means of divalent metal transporter 1. Now, this mucosal ferritin again has to enter the blood circulation. This takes place with the help of ferroportin, which is present on the basolateral side of the duodenum. So, the Fe2+ that comes out of the ferroportin has to be oxidized to Fe3+, so that it can combine with the plasma transferrin in order to go to the liver and bone marrow, as I have suggested in the previous slide. So the Fe2+ that enters into the blood circulation has to be oxidized by hepestin, which is present on the basolateral cell, so that it gets converted to Fe3+, so that it can combine with the plasma transferrin and can enter the blood circulation. So now this combined Fe3+ and plasma transferrin enters the liver. So as we all know that liver is a storage organ, it mainly senses the iron stores. So whenever the iron stores are replete, or whenever the iron stores are full in the liver, full to the fullest form in the liver secretes hepcidin. This hepcidin has a negative impact on ferroportin. So increased hepcidin causes disintegration and inactivation of ferroportin. So when this ferroportin gets inactivated, this Fe2+ cannot come outside the duodenal enterocyte. So, so mainly hepcidin and ferroportin are the two main regulators of the iron metabolism. Iron metabolism in pregnancy. Iron absorption in pregnancy increases from 7% in the first trimester to 66% in the third trimester. Whereas our iron from the dietary, whereas the absorption from our diet is only 1 to 2 milligram per day. The requirement in second trimester is 4 to 6 milligram per day, and requirement in third trimester is 6 to 8 milligram per day. Now, total iron requirement in pregnancy. The total iron requirement in pregnancy is about 1000 milligram, which is distributed over the course of the 9 months. So where does this iron go? Mainly 300 milligram of iron goes to the fetus and placenta. There is an increased RBC mass in pregnancy, so 500 milligram is taken up for that. There is a loss of delivery, which is 200 milligram, and loss through urine, sweat, and feces, that is 200 milligram. We have a saving of about 200 milligram. We have a saving of about 200 milligram, which mainly occurs due to the amenorrhea for a period of 2 months. So totally there is 1200, of which there is only a 200 milligram of saving. So 1000 milligram of iron is totally required in pregnancy. Increased RBC mass. Now, what is the cause for this increased RBC mass? There is physiological macrocytosis in pregnancy. Pregnancy is a state where there is an increased O2 demand, both for the mother as well as baby. So in order to meet the increased O2 mass, there is physiological macrocytosis in pregnancy. And also there is an increased production of erythropoietin from the 10th week of pregnancy that also leads to increased RBC mass. During the second trimester, requirement is high. 4 to 7 milligram of iron needs to be absorbed compared to 1 to 2 milligram per day. To meet this increased requirement, diet proves to be insufficient because only 1 to 2 milligram roughly gets absorbed. So iron supplementation is given from the second trimester. Iron supplementation is also given from the second trimester because in the first trimester, mother herself has GI symptoms like nausea, vomiting. So providing iron in the first trimester leads to aggravation of those symptoms. Now, hepcidin and ferroportin in pregnancy. Always in pregnancy, the ferroportin is increased and the hepcidin is decreased. Hepcidin has a negative impact on ferroportin. So hepcidin level decreases. So there is increased iron absorption from the gut. In women with poor nutritious diet or those not taking supplements, stores are mobilized back into circulation. Ferroportin is also the same protein that helps to carry the iron from the reticuloendothelial system back into the circulation. There is increased ferroportin, so increased mobilization from stores. Also, there is need to supply iron to the fetus. So ferroportin is increased and hepcidin is decreased in pregnancy. So this is the relationship between hepcidin and iron metabolism. As you can all see, when hepcidin is increased, it causes a negative impact on the ferroportin. So here there is increased hepcidin. So hepcidin inhibits iron export from the hepatocytes, and also it also inhibits the iron export from the duodenal enterocyte. It also inhibits the iron export from the splenic macrophages. So iron entry into the blood is restricted when the hepcidin is increased. Whereas when the hepcidin is decreased, iron export into the blood is increased from the liver, duodenum, and the splenic macrophages. Ferroportin and iron. Ferroportin, this blue color cylindrical structure is the ferroportin. The ferroportin, as you can all see, ferroportin is present in the liver, it is present in the enterocyte and also in the macrophages. So with the help of ferroportin, the Fe2 plus comes outside the liver, and in the plasma, it combines with the plasma transferrin Fe3 plus. So the Fe3 plus plasma transferrin complex enters the blood circulation. So ferroportin is present in the liver, enterocyte, and also the macrophages. And hepcidin has a negative impact and causes a disintegration and inactivation of ferroportin. So ferroportin has to be increased in pregnancy in order to improve the iron absorption. Physiological anemia of pregnancy. Why does physiological anemia happens? The blood volume increases by 30 to 40% and the RBC mass increases by 20 to 30%, whereas the plasma volume increases by 40 to 50%. So physiological hemodilution occurs. It is reflected in the blood picture as a decreased hemoglobin and decreased hematocrit. So hemodilution occurs. It starts at 7 to 8 weeks, reaches a peak at 32 weeks, when the blood volume and also the plasma volume changes are peaking. This is the blood picture of normal women and also the pregnant women. As you can all see that here there is hemodilution, and here there are many red blood cells, fewer red blood cells. There is a normal hemoglobin, low hemoglobin. There is physiological macrocytosis in case of pregnancy. Why hemodilution occurs? It is a nature's way of protecting for the blood loss that occurs during delivery. There is decreased viscosity of the blood, so there is increased blood flow to the uterus and placenta. It also decreases the cardiac load in pregnancy. What happens normally in pregnancy? Normally in pregnancy, the hemoglobin decreases, hematocrit decreases, serum ferritin decreases, serum iron decreases, total iron binding capacity increases, transferrin saturation percentage decreases. These are all reflected in iron deficiency anemia also. But pregnancy is like an iron deficiency state, but with a subtle difference. So what are the difference? The mean corpuscular volume is slightly increased. That is the physiological macrocytosis that happens in normal pregnancy. The mean corpuscular hemoglobin decreases, which is the same as that of iron deficiency anemia. The mean corpuscular hemoglobin concentration is normal, but in case of iron deficiency anemia, MCHC is also decreased. So now let's compare physiological anemia and iron deficiency anemia. The MCV slightly increases, MCV decreases in iron deficiency anemia, MCH decreases in physiological anemia, MCH decreases in iron deficiency anemia. MCHC, that is mean corpuscular hemoglobin concentration, is normal in physiological anemia, whereas it decreases in iron deficiency anemia. Both the cases have low hemoglobin and low hematocrit. Back to basics. Why is basics so important? Why is physiology so important? We learn so many complex diseases and their treatment, but we need to come back to our basics, the physiology, to understand the pathology better. Anemia in pregnancy is an indirect contribution to increased mortality and morbidity. 17% of the maternal mortality is caused by anemia in India. Double-edged sword. Anemia is a double-edged sword when it is combined with multiple pregnancy or PPH or APH or hypertensive disorders, preeclampsia. So we have to prevent anemia. Complications of severe anemia in pregnancy. What are the complications? Severe anemia lead to cardiac failure. There is increased risk of abortions in pregnancy, preterm labor, postpartum hemorrhage, infection, and during the puerperium, there is subinvolution of uterus, deep vein thrombosis, poor wound healing, lactation failure. Whereas the fetal complications include abortions, IUGR, low birth weight, perinatal mortality, reduced iron stores in pregnancy, chronic diseases like hypertension and diabetes mellitus in future because of the increased placental weight and fetal weight ratio. So anemia is a double-edged sword when it is combined with other disorders like APH, PPH, preeclampsia, hypertensive disorders, and multiple pregnancy. It causes an increased morbidity and mortality. Prevention is always better than cure. Oral iron supplementation in pregnancy alone is not enough. We have to improve the women's hemoglobin during adolescence. That is very mandatory. We have to ensure the women enter the reproductive age and pregnancy with the right hemoglobin in order to prevent morbidity and mortality caused by anemia. Happy pregnancy. Thank you.
That was a very nice presentation, Dr. Krishna.
Thank you, ma'am.
So I have two questions for you. One is, you said there is a low hemoglobin also in both in iron deficiency and physiological anemia of pregnancy. But there is one cutoff value to say it is physiological. It should never be less than
10. Physiological anemia less than 10.5.
Yeah, it should not be less than 10. Okay, so if it is less than 10, it is no longer physiological. Okay, that is one cutoff. Then you said there is preterm labor in anemia. How can we explain preterm labor in anemia in pregnancy?
Because of the increased interleukins like IL-1. Which
so there is a that is right. So there is a rise of inflammatory markers. Okay. And how do you explain IUGR in anemia in pregnancy, intrauterine growth restriction?
There is a decreased blood flow to the placenta, and there is hypoxia associated with anemia.
Okay. And what is the cause for cardiac failure if anemia in pregnancy?
Cardiac failure, there is increased workload in case of anemia.
Okay, so cardiac myocyte has to pump harder.
Okay,
thank you. We'll go to the next speaker.
Thank you.
Thank you, Doctor.
Thank you. That was a good presentation.
Madam, Vijay Madam, we can't see you.
Yeah.
Yeah. Sorry, actually, I'm out of station, but
I'll introduce Yeah, it's nice to see you, Madam.
I'm happy to
Madam, will
introduce.
you call the second candidate? Yes.
Yeah. Is
Dr.
it
Selvarani.
Dr. Selvarani Jayaraman? Yeah. She's the chief consultant and former medical superintendent at St. Joseph's Hospital and at Dindigul, and she's the honorary treasurer of DSOG, Dindigul OG Society. And she has presented many papers and posters in district and national forums, and her special interests are in infertility and high-risk obstetrics. She has graduated from Raja Muthaiya Medical College and holds a diploma in diabetology, sonology, and as well as laparoscopy, and postdoctoral fellowship in reproductive medicine and embryology. And she has several diplomas to her credit, and as well as FICOG. Over to you, Dr. Selvarani, for your presentation.
Thank you, ma'am, for your kind words. So good evening, dear madams. So let me today discuss in brief about investigations of anemia. First of all, let us have a glance on the classification of anemia. Anemia is classified as physiological anemia of pregnancy and pathological type. Physiological anemia is due to hemodilution, and pathological anemia is further classified as iron associated with nutritional deficiency, iron deficiency, folic acid deficiency, vitamin B12 deficiency, combined deficiencies, protein deficiency, and a hemorrhagic acute due to blood loss in APH, and chronic due to worm infestations, bleeding piles, and etc. So anemia is associated with decreased production of blood cells due to bone marrow disorders, bone marrow suppression or suppression due to steroids, other immunosuppressants, or other chronic kidney disorders, or even hypothyroidism. Anemia associated with increased restriction of red blood cells in hemolytic anemias, inherited in sickle cell anemia, thalassemia major, hereditary spherocytosis, and other hemoglobinopathies. In acquired, it is due to autoimmune hemolytic anemia. Hemolytic anemia associated with thrombotic, thrombocytopenic purpura, hemolytic uremic syndrome, and malaria. And due to blood loss of various obstetric hemorrhage, due to concealed abruption, previa, and other causes of APH, variceal bleeding, trauma, anemia of infection due to malaria, tuberculosis, chronic renal disorders, leukemia, Hodgkin's disease, and PNH. So the objectives of investigating and classifying the various types of anemias are to ascertain the degree of anemia, type of anemia, cause of anemia, severity of anemia. To know the degree of anemia requires estimation of hemoglobin, total RBC count, PCV. And to know the type of anemia, we need a peripheral blood smear, hematological indices like MCHC, MCV, and MCH. To know the severity of anemia, hemoglobin, and hematocrit. Other blood values of importance are serum iron, total iron binding capacity, and serum ferritin. The examination of stool sample to know the helminthic infestation. Urine examination for hematuria, protein loss, sugars, and pus cells. And bone marrow study is not a routine, but indicated in a special times as case not responding to the medical therapy. Hemoglobin and hematocrit estimation, mandatory to estimate the severity of anemia. Peripheral smear helps us to differentiate between the iron deficiency anemia and vitamin B12 folate deficiency. Red cell indices should also be determined. Anemia can be differentiated by the mean corpuscular volume. Low mean corpuscular hemoglobin concentration is a sensitive index of iron deficiency. Red blood cell distribution width gives us the measure of variation of red blood cell volume, reflects the degree of anisocytosis of red blood cells. The normal range diameter is 6 to 8 micrometer. A high value indicates dimorphic anemia. Serum ferritin is the sensitive index of iron deficiency anemia. Ferritin levels less than 15 microgram per liter or diagnostic of iron deficiency. Treatment should be initiated when levels are less than 30 microgram per liter. Serum iron and total iron binding capacity gives us when serum iron less than 30 microgram per deciliter and total iron binding capacity more than 400 microgram per liter or indicative of iron deficiency anemia. Serum transferrin receptors present on all the cells as transmembrane protein that binds transferrin iron and transfer it into the cell interior. It is increased in iron deficiency anemia. This next is the flow chart. In anemia where the hematocrit and the hemoglobin parameters, where the hematocrit less than 30% and hemoglobin of less than 10 gram per deciliter, where there is low MCV that is less than 80%. Here we have the iron studies like increased total iron binding capacity and decreased serum iron ferritin, suggestive as for iron deficiency anemia. And if the iron studies are normal and the hemoglobin A2 level is more than or equivalent to 3.5%, that is beta thalassemia minor. And if it is normal, we have to go for the family studies and investigations to rule out alpha thalassemia minor. And the hematocrit is less than 30% and the hemoglobin is less than 10 gram per deciliter, a normal MCV, they have to do the peripheral smear and the reticulocyte count. If the rectix is more than 2 to 3% and we have abnormal RBC morphology, there is definitely of hemolysis, could be hemoglobinopathy, inherited RBC membrane defects, drugs, or autoimmune or G6PD deficiency. If it is normal RBC morphology, it might be of any bleeding parameters. And the rectix is normal or low, there is impaired RBC production, due to drugs, any chronic disease, bone marrow pathology, mild iron deficiency. If it is high MCV, could be a folate plus B12 levels. We have to go for the folate and B2 levels and peripheral smear. If the folate is less than 3 nanogram per ml and B12 is less than 80 picogram per ml, with hypersegmented neutrophils, we can definitely say it as a folate or B12 deficiency. So, this commonly encountered anemias like iron deficiency anemia, where hemoglobin and hematocrit or low in iron deficiency anemia, we can go by complete blood count. If there is a low or red blood cells, normal or elevated WBCs or elevated platelet count. If the red cell indices are low, MCV less than 8 femtoliters, a low MCHC less than 30%, and if the peripheral smear suggestive of microcytic hypochromic RBCs and anisopoikilocytosis. In iron studies, low serum ferritin levels, low serum iron levels, elevated total iron binding capacity. So the next is the megaloblastic anemia, and that is B12 and folic acid. This folic acid deficiency, we can see low hemoglobin, and there is macrocytic RBCs. In MCVs, there is more than 100 femtoliters, and there will be hypersegmented neutrophils, low serum folic acid levels. There is elevated serum LDH levels, elevated serum homocysteine levels. In B12 deficiency, of course, here low HB, low RBC count, high MCV, that is more than 100 femtoliters, normal or low MCHC, normal or low reticulocyte count, normal or low WBC count, peripheral smear suggestive of macrocytic RBCs, hypersegmented neutrophils, serum levels of low vitamin B12 levels, and high homocysteine levels. Aplastic anemia. Anemias like anemia, leukopenia, and thrombocytopenia. In bone marrow, there is markedly hypocellular picture. In the sickle cell anemia, there will be refractory hypochromic anemia, identification of sickling test, persistent reticulocytosis about 10 to 20%, high fasting serum iron level, identification of the type of hemoglobinopathies by electrophoresis method. And in thalassemia, there is a low MCV and MCH, but normal MCHCS, HC serum iron and total iron binding capacity are normal or elevated. Hemoglobin electrophoresis shows raised concentration of HbA2 to more than 3.5% with normal or raised HbF. Serum bilirubin may be raised to about 2 to 3 mg/%. If we take the blood picture, there will be microcytic hypochromic anemia, anisopoikilocytosis, normoblast, and there will be fragmented RBCs. Target cells, reticulocytosis, and there will be raised indirect bilirubin, reduced MCH or MCHC, and reduced total iron binding capacity. In thalassemia major, there will be electrophoresis, hemoglobin F to be 30 to 98%, and hemoglobin A2 is to be around 2%, and there will be no HbA. In thalassemia minor, HbA2 will be around 3.5 to 7%, and in HbF, there will be raised, HbF will be raised, that is more than, less than 5%. Next slides. So in a normocytic anemia, we can go for the differential diagnosis when there is low hemoglobin. We can go for the reticulocytes count. If the reticulocytes counts are normal, we can go for the differential diagnosis. Could be anemia of chronic disease, anemia due to renal failure, or early folate deficiency, early B12 deficiency, or any other effects on drugs. Or if there is a increased in a reticulocytic counts, there will be due to hemolysis or due to blood loss. So in microcytic anemia, the differential diagnosis. So obviously low hemoglobin with the MCV less than 80 femtoliter. We can go for the reticulocytes count. If it is normal, we can go for the ferritin, serum ferritin or iron percentage saturation. Even all this normal, advised hemoglobin electrophoresis to rule out thalassemia and HBE and anemia of chronic disease and sideroblastic anemia. If the serum ferritin or iron percentage saturation is low, likely iron deficiency. And if it is increased reticulocytes count, we may expect the spirocytosis. And if it is absent of mainly of inherited membrane or enzyme defect, the spirocytosis is positive, we may advise for Coombs test. And if the Coombs test is positive, we can label as immune hemolytic anemia. And if it is negative of Coombs test, it is hereditary spirocytosis. So the differential diagnosis of macrocytic anemia, where our hemoglobin is low and the MCV is more than 95 femtoliter and the RBCs with macrocytes. If the reticulocytes counts are normal or decreased, there will be number of macrocytes and no hypersegmented polymorphs. Bone marrow is not megaloblastoid. These suggestive to rule out refractory anemia, any drugs induced liver diseases, aplastic anemia, myeloid dysplasia, or sideroblastic anemia. If the reticulocytes counts are increased of hemolytic anemia, normal or decreased could be macrocytes with the hypersegmented polymorphs of vitamin B12 deficiency or folic acid deficiency. So thank you.
Thank you, Dr. Selvarani. That was a very interesting presentation. I have a few questions for you. What is sickling test? Suppose if normal, you have done a peripheral smear for somebody who has come from Odisha.
Yes, ma'am.
You find a peripheral smear is normal, but then you have a risk factor for screening for sickle cell. So,
yes, ma'am.
So in the laboratory, in the lab investigations, can you ask for adding sodium metabisulfite to the patient's blood and then inducing the sickling and then taking a peripheral smear? Something like sickling test for high groups, high risk population.
Yes, ma'am, we can do.
Okay, then what is the role for retinal screening?
Retinal
screening. If there is in which type of anemia we will do retina screening?
Thalassemia, ma'am.
Basically, it's proliferative retinopathies can happen if there is hypoxic crisis in sickle cell anemia. So you may get proliferative changes in the eye. Okay. Okay. So that was a very nice presentation. Thank you, Doctor.
Vichi, madam, you have any questions,
Yeah.
madam?
Yeah, and Dr. Selvan, what is this hypersegmentation of neutrophils? Why does it happen? Especially when you have macrocytic anemia.
Because of presence of 5% or more neutrophils, ma'am, with more lobes or in the single neutrophil with more lobes or due to deficiency of folate and impaired DNA synthesis, ma'am.
Yeah, yes, it's mainly because of the impaired DNA synthesis, and the step where the folic acid is being utilized is absent. It tends to become hypersegmented. Yeah.
Yes.
Thank you, Dr. Selvarani. It was a very nice presentation.
Thank you.
Thank you.
Thank you, judges. Thank you. So we come to the end of the session one. So can we have the questions if they are ready? Chitra? We have a few questions. So I hope it is strictly only for the audience and not for the faculties. So I would request only the audience to participate in the quiz. Yes, the questions, please. Folic acid rich foods include all except leafy greens, pork and ham, lentils, peas, beans, or broccoli. 4 choices. Clock is ticking. No one has answered.
Ma'am,
Come on,
answering,
audience,
ma'am.
wake. They're answering?
Yeah. Yes, ma'am, 30% answered. Another 15 seconds to go.
Yeah. Come on, audience, wake up. We have quiz time. 30%. No, we want everybody to answer.
Time up, ma'am.
Yes. So can we have the
next question? Yes, ma'am.
Yes. Regarding iron supplementation in pregnancy, which is correct? Should not be taken on empty stomach. It is better absorbed with citrus fruits. Can be taken with caffeine. Can be taken with milk.
Ten seconds to go.
Yes. How many percentage of answer?
52% answered, ma'am.
Okay. Nice.
Time up.
I think we have one more question now.
Yes, ma'am.
Yes. The sensitive indicator of iron stores. This was there in the CME. So whoever has listened, they're going to get the full marks. Ferritin, transferrin, percentage transferrin saturation, hepcidin. Sensitive indicator of iron stores.
Another 15 seconds to go. 52% answer.
Good. Audience, great going.
Time up.
Yes, thank you. So that is a short, like for the waking the audience up, we just had a short interruption. We will be having further interruptions now and then. Yes. So it is my great privilege to invite our chairperson and for the session 2, Dr. Ramani Devi Madam. Madam is the Managing Director of Ramakrishna Medical Center and Janani. Madam, Janani Fertility Center. Madam has won 10 gold medals in UG and PG. She's been a chairperson of Endometriosis Committee, and Madam has been the Women of the Year Award from Bharathidasan University, Women Achiever Award, APJ Abdul Kalam Award, a recipient.
Yeah, I think you can stop it. We will straight away go to the talk.
Okay, Madam. Thank you.
Okay,
I would over to the chairperson.
Okay. See, it is indeed my great pleasure to introduce my friend Dr. T.K. Shanti to deliver this talk on thalassemia. She is a consultant in ONG at Mangalam Healthcare Center, past president of OXY, former director and superintendent of Institute of. Shanti. She is a very good human being and a very good academician and has got a great knowledge, and she is taking part actively in the Menopause Society of activities. Welcome, Shanti. I think that today the topic is thalassemia. Thalassemia, even though you see it in rare pockets of Tamil Nadu, it's very, very important because counseling and management becomes the most important thing to have a safe baby and a mother. Go ahead, Dr. Shanti.
Thank you very much, Ramani. Can I share my screen?
Yes, ma'am.
Yes, ma'am. Yes. Yes, ma'am. Your screen is shared. கீழே இருக்குல்ல மேம் thalassemia. Yes. Yes.
Is my screen seen?
Yes, madam. Yes.
Yeah.
Yes.
Yeah. So the topic is thalassemia in pregnancy. And we know that it is the most common congenital monogenetic disease in the world. Earlier, it was more in certain pockets of Africa and Mediterranean region. But then now, because of migration, it has achieved global prevalence. The important thing is it is quantitative defect in hemoglobin synthesis due to a reduced rate of production of one or more globin chains. And the classification is based on the specific globin chain that is affected. So why is it really important? We know anemia is very common and we think there is a set pattern of treatment. But then we understand that thalassemia can be really very debilitating. It heavily burdens the families and the health sector. And India dubiously has the largest number of thal major children in the world. So the cost accrued is really very, very high. And also treatment is not like iron deficiency anemia, which it seems to mimic. So the main thing is it is mutation in one or more of the genes. And we have alpha thalassemia and mutation, if it affects one, it is called as thalassemia silent carrier, and which is really very asymptomatic. But then if the mutation affects 2 of the 4 genes, still it can be asymptomatic or mild symptoms. This is the alpha thalassemia minor. We have if the mutation affects 3 genes, then it is called as hemoglobin H disease. And if it is affecting all the 4 genes, it results in hemoglobin Bart's hydrops fetalis. Alpha thalassemia as such is not very common in India, but it does not mean it does not exist. It is there. And especially if the person is suffering from mutation affecting all the 4 genes, hydrops fetalis can result from 23 to 38 weeks. And also, even after delivery, transfusions might not help the baby much. So that is the importance, although alpha thalassemia is quite rare. So generally, we see microcytic anemia. In Bart's, we see severe microcytic anemia with pronounced hepatosplenomegaly with hydrops fetalis in utero. Then coming to beta thalassemia. So the alpha thalassemia was decreased production of alpha chains. So beta thalassemia is decreased production of beta globin chains. So because of that, what happens is the unmatched alpha globin chains accumulate and aggregate, leading to excessive hemolysis and impaired bone marrow erythropoiesis. So we have 3 syndromes. One is beta thal major, which is severe transfusion dependent. That means more than 7 transfusions per year the person will be receiving. Thal intermedia is also homozygous like beta thal major, but then there are certain genetic differences. Anemia is seen, splenomegaly is seen, less frequent transfusion. That means 7 and less. We have the third variety, which is thal minor or beta thalate. That means they have only one abnormal globin chain. And here they are just carriers. They do not suffer much. So all three are by autosomal recessive inheritance. So thal major is more disabling. Thal intermediate is intermediately disabling. Beta thal trait is usually asymptomatic, but then can lead on to thalassaemic children if two thal carriers marry. So how do we screen for thalassemia? So it is very, very important that we have to look at complete blood count properly. So everywhere we do not do hemoglobin alone anymore. It is CBC which is being done. So in thal trait, there will be reduced MCV, reduced MCH, and a normal to a near normal mean corpuscular hemoglobin concentration. Unlike iron deficiency anemia, where there is also reduced MCV, reduced MCH, but MCHC is also decreased. So MCHC being normal or near normal is very, very important. And MCH is the most accurate marker. In beta thal, as Selvarani said earlier, in hemoglobin electrophoresis, there will be elevated hemoglobin A2 levels. But then we have to do DNA analysis to confirm the diagnosis. And we should also do iron studies to rule out iron deficiency and also to know the degree of iron overload in thalassemia. That seems sort of incongruous, but then that is very, very important. We give them iron, even oral iron, only if there is iron deficiency. Even otherwise, especially in thal major, they can have iron overload. So serum ferritin once in 6 months is very, very important to be done routinely. So how do we prevent thalassemia? Prevention is very vital, and genetic counseling is done in countries with high incidence of thalassemia. For us, Gujarat, Maharashtra, and all these tribal areas. From Tamil Nadu, I have seen even Tamil people not belonging to tribals or Saurashtras. Even I've detected beta thal trait in such people. Okay, especially in the Tirunelveli belt. And it is very important to warn carriers against consanguineous marriages or marrying partners with beta thal trait. So any person with beta thal trait should not marry another person with beta thal trait. And especially if this unfortunately happens, invasive prenatal diagnosis is the gold standard, and which can be done by chorionic villus sampling, amniocentesis, or even by fetal blood sampling. We know CVS 10 to 12, amniocentesis 16. If they come later, 18 weeks cord blood sampling, fetal blood sampling. And pre-implantation diagnosis can be done if they opt for IVF. So what are the maternal risks in transfusion-dependent thalassemias? So I said thalassemias are threefold, beta thalassemias. So the major and intermediate are transfusion dependent. Trait does not cause much problem. So cardiac failure, alloimmunization, that is very, very important. So because of that, blood transfusions can be problematic. It is very difficult to cross-match because they contain a lot of antibodies, viral infections, thrombosis, osteoporosis, endocrinopathies like diabetes mellitus, hypothyroidism, and hypoparathyroidism due to increasing iron burden. And in alpha thalassemia, that is the fourth one, HP parts, there can be mirror syndrome with early onset preeclampsia in women with high drops and primary PPH. What are the fetal risks? Neural tube defect can be there. So all thalassemics, even if they are carriers, should be on high dose folic acid, that is 5 milligram. Fetal growth restriction can be seen. And in carriers, the important thing is inheritance of beta thal by the fetus and fetal high drops in HB Bart's disease. So how do we manage during pregnancy? So any pregnant woman, if you suspect, we have to screen the individuals whether they are at increased risk for thalassemia or thal carrier. If they are carriers, then screening of partners should be done immediately. If positive, urgent genetic counseling followed by prenatal diagnosis. So the preconceptional care of thal major is very, very important. It is a multidisciplinary evaluation. Recurrent blood transfusions will be given. Usually, it will be given an aliquots of 2 Paxils. They will be on iron chelation, desferrioxamine, which reduces end organ damage. Diabetes, hypothyroidism, and hypoparathyroidism should be looked for and corrected. Cardiologists to assess the cardiac status. Even MRI has been recommended and CT. So bone density scan to treat osteoporosis. Vitamin D. Vaccination against hepatitis B, pneumococcus and Haemophilus influenza type B must be given. Folic acid 5 milligram per day to prevent neural tube defect. Thal treatment just needs the folic acid, does not need any other evaluation. So what is the antenatal care? So I told you already about the multidisciplinary team. And hemoglobin should be done every 2 to 3 weeks. If less than 10 gram per deciliter, a 2-unit blood transfusion is given. If ferritin is less than 30 milligram per liter, then oral iron supplements are given. There is no role for parenteral iron. All anemias, we take recourse to iron sucrose right and left, especially when it is microcytic hypochromic, thinking it is iron deficiency anemia. So it's very, very important to look at MCV, MCH, MCHC. MCHC will be normal in thalassemia. Also, the RBC count will be high, normal, or even increased. And desferrioxamine can be restarted in 2nd and 3rd trimester. Folic acid has to be continued as usual for like other pregnancies. First trimester screening for Down syndrome and TIFA are done. But what is important is serial biometry scans every 4 weeks from 24 weeks to rule out fetal growth restriction. In thal trait, certain recommendations talk about prophylactic oral iron, but some do not talk about that. And therapeutic dose is given in iron deficiency anemia. So iron deficiency has to be evaluated well if you really diagnose her as beta thal trait with anemia. No parenteral iron. How do we care for them intrapartum? We already have a big multidisciplinary team. Along with that, anesthetist and neonatologist are added. Cesarean delivery is only for obstetric indications. And when any thal patient comes into labor, it is mandatory to have at least 2 units of cross-match blood arranged prior to delivery, because that time it might not match because they are very prone for alloimmunization. Intravenous desferrioxamine is given 2 grams over 24 hours. continuous intrapartum electronic monitoring, and routine care only for alpha thal and beta thal range. Postpartum management of transfusion-dependent thalassemia is low molecular weight apparent for a week following discharge from hospital. It is not 1 week after delivery. Low molecular weight apparent for a week following discharge after a vaginal delivery and 6 weeks following cesarean section. Breastfeeding is encouraged. Desferrioxamine is restarted. Folic acid is to be continued in thalassemias, both transfusion and non-transfusion dependent. No contraindication to hormonal methods of contraception. Newborn should be screened, but then only in thal major, probably a few cases, we can be able to pick up. Usually after 6 months to 1 year only, we are able to identify when. And newborn of hemoglobin bars, that is alpha thalassemia, where all the 4 chains are affected, might need transfusion. So we have here 23-year-old primary gravidas whose CBC shows 10.5 grams. So it is anemia. RBC, MCV is less, MCH is less, MCH is less, but MCHC is normal. What is important is we have to look at RBCs. Any iron deficiency anemia or RBC will also be less, 3.9, 3.8 like that. Here it is high normal. So probably thalassemia. We will evaluate with hemoglobin electrophoresis. Okay, we have a program by our central government where they are really bent upon identifying a lot of these thalassemia, unfortunate thalassemia women. So for field things, Nestroft is advocated. So it is naked eye single tube red blood cell osmotic fragility test that is quite specific. Okay, so here routinely we do not give oral iron. If she has anemia less than probably even up to 8, that is what a hematologist say. So if it is really less, then probably we will do iron studies. If necessary, we will put them on iron. Folic acid has to be continued postpartum too. Obstetrically, no problem at all. But the baby has to, so the most important thing is they have to undergo, the husband has to be also screened, and if negative, no problem. If positive, she will undergo investigation to know whether the baby is positive or not, either carrier or thal. So that is very, very important. Carrier, no problem, but thal means probably we have to offer termination. So all these things we have to talk. And this is a case 2 patient, known thal patient, primary with 6 weeks pregnancy, comes with hemoglobin of 9.5. So the multidisciplinary team will evaluate them completely. Folic acid should be given. And if because the hemoglobin is less than 10, in thal major, we will be giving 2 units of Paxils. Then from the second trimester, we will be starting her on desferrioxamine. Then labor, try to give her a vaginal delivery as much as possible. She has to be monitored by all specialists. And postpartum, she should have low molecular weight apparent at least 1 week after discharge if she has had a vaginal delivery, or 6 weeks after a C-section. The child also has to be evaluated. And 23-year-old primary gravida with a thalassemia, HP bars comes for ANC. We follow them up regularly, but we should know that they can go in for fetal eye drops. So intense monitoring. So thal major also repeated scans after 24 weeks. So here also we have to continue like that. We have to look out for eye drops. And that can also cause hazard to the mother in the form of mirror syndrome. So all these we have to note and then again review the baby again. So to conclude, proper management of a pregnant transfusion-dependent thalassemia woman by appropriate monitoring during antenatal, intrapartum and postpartum periods and monitoring and testing of fetus will give a good outcome. Pregnancy outcome does not differ from the general population in alpha thal carriers, alpha thalassemia, beta thal carriers, but prenatal testing is indicated. High index of suspicion of thalassemia by properly noting the CBC and subsequent evaluation should prevent a thalassemia baby being born. But then counseling is very important if she is found to be a beta thal carrier. And of course now and cord blood banking is very, very important, especially if the baby is thal-free in this pregnancy. It might be useful for an affected sibling. So that is also there. Bone marrow transplant also now has come into vogue very well, which has really helped thal patients. But as obstetricians, we should know that all microcytic hypochromic anemia are not iron deficiency anemia. There are other anemias too, where iron should not be pumped in, especially the parenteral iron. So thank you very much for the patient hearing. And I thank Professor Sampath Kumari for the opportunity. Thank you.
Sorry. Can you hear me now? Yeah. Dr. Shanti, it was a very good deliberation and you had you had given a clear-cut idea about thalassemia major, thalassemia minor, and then alpha and beta thalassemia. And you have stressed the importance of pre-pregnancy counseling as soon as the baby is born. And if the patient has got anemia in the early adolescent phase itself, we have to have a look at it and then evaluate for thalassemia, any trait or trait of thalassemia. See, again, now there is a hope, ray of hope that even thalassemia, severe thalassemic patients can also have a baby of their own by all the recent advances that has happened. And when they are getting married, trait is not going to matter much, but if they are going to have a thalassemia, this one, they have to get evaluation of the partner has to be done so that it can avoid so many other complications. My one question for you is, if the thalassemic status of the partner is not known, and if the patient is found to have a moderate anemia, then would you go for a chorionic villus sampling or amniocentesis to find out the thalassemic trait of the baby?
No, if the husband is not here, even and from abroad, he can have a testing done and then send. So,
okay,
because
that's okay.
interventions, yeah.
But most of the time, we do not know the trait of the husband. They become pregnant with us. Then only we analyze. Okay, so if the husband is available, then we can
bring them in, and then it is mandatory. We should tell. But sometimes the husband need not be the father of the child also. That is also there in certain conditions. But still, we can really add. All these people understand the importance very well. But if no other thing is possible, then probably we will decide. But then interventions are associated with 1 to 2% fetal loss, however advanced, at least in counseling. So I think we have to bring in the husband unless he's not at all available. Probably then we can take recourse to it.
Thank you, Shanti.
Thank you very much.
Anybody wants to have any question? You can unmute and talk.
We have good guidelines by our government of India. I think all of us should go through it. That is very, very important. And especially people in service, so much is written very nicely in a simple manner, which can be followed even in a primary health center.
Okay. Thank you.
Thank you, madam. That was such a wonderful talk, and that was so enlightening. So you gave us a lot of information. So we have a few questions for the audience. So it's not for the faculties, it's only for the audience. So Chitra, can we have the questions, please? Okay, audience, wake up. We are just going to go and give the questions. So the best investigations to diagnose thalassemia: hemoglobin, PCV, HB electrophoresis, MCHC. Audience, from the discussion with Dr. Shanti madam, it should be crystal clear now. I think all of them will get it correct. Okay, the time over, Chitra.
10 seconds more, ma'am.
Okay, 10 seconds. Come on, buck up, all of you answer. Everyone answered?
52% answer, ma'am.
Oh, not bad.
Time up, ma'am.
Time up. Thank you. So now, after all the enlightening talks about anemia, we are going to go ahead with the panel discussion, the much awaited panel discussion. So, okay, so that will be, can we have the panel moderator? Yes. Dr. Shivakami Ilango madam. Madam is a consultant obstetrics and gynecologist and a lab surgeon. Madam has done her UG from Tirunelveli and has done her MD from Stanley Medical College, got the diploma in laparoscopy, and she's a live member of endoscopy and laparoscopic surgery. She's there in the Tamil Nadu government service and in Madurai Medical College for 12 years. She's been the winner of the CS Dawn Prize, and she's been faculty in various scientific sessions, discussions, and she's the director of Shubham Hospital in Tirumangalam, Madurai. Can we have the next person, please? Madam Dilshat madam. Madam is a MD DGO FICOG. Madam is a consultant, Crescent Hospital, Madurai. She is an academic faculty in Velamal Medical College and Research Institute, and she's been a former director of KGH and MMC. And Madam has been the professor and HOD of Rajaji Hospital, Madurai. Madam is the president MOGS from 2009 to 12. Executive committee member as well as a faculty in ASCOG, and Madam has presented many papers and posters. Over to the moderators to invite your panelists, ma'am. Or shall I go with the panelists as well?
Yeah.
Madam?
Madam? Yes, you can. Am I audible?
Yes, madam. Yes.
Yeah. Oh. You can go ahead with the introduction of the panelists.
Okay, madam. So it is a great pleasure for me to invite all the panelists for this discussion. Dr. Shujata Alagasan, madam. Madam is a professor of Ops and Gyn, Tirunelveli Medical College. Madam is a Foxy Tirunelveli branch secretary for 5 years, conducted live Ops and Gynecological workshop. Madam has presented national papers and won the Best Paper Award in UA Foxy and be a national faculty in ASCOG. Next slide, please. Madam Anuradha madam, she's a consultant Ops and Gyn SS Hospital Tiruvannamalai. Madam has been MBBS candidate from Chengalpattu, MD from Madurai Medical College, and madam has been an IMA president from Tiruvannamalai and the Women's Wing secretary in 2018, presented papers in IMA and national conferences. Next, please. Gomati madam is a MD DNB Ops and Gyn consultant in Bebel, Sudarshan and KC Hospital, former assistant professor in RSRM. She has done a UG from KMC, PG from Stanley. She's been an Oxy Life member and won the Esture Gold Medal Award in Contraception Quiz. 9 years of experience with special interest in high-risk obstetrics, infertility, lap and colposcopy. The next slide, please. Dr. Shwati, she has completed a UG PG from Tanjavur Medical College, worked as an assistant professor in Tanjavur Medical College, and presently working as a consultant in NM Hospital, Tanjavur. Madam's field of interest is gynae, endoscopy, and infertility. Tejovati madam, she's a senior consultant Ops and Gyn in Skadar Memorial Hospital. She has done her MSOG and DGO from Christian Medical College, Vellore. Madam has a special interest, her thesis was on the beta HCG levels in the ectopic patient, and she has done a research article on abdominal wall endometriosis.
and Madam is a consultant in SM Hospital, Ranipet. Next, please. Dr. Vairamala, Madam, she's an associate professor, Ops and Gyne Department of Tiruvallur. She has an MBBS from Madras Medical College, MD from Coimbatore, Best Doctor Award from the department in the August KMC winner and IMS quiz. Trainer in all the obstetric drills. She's been a laparoscopic trained person. She is a DGM special trainer and training for IUI semen preparation as well. Next, over to you, Madam. So over to the moderators.
Good evening to all. We thank the TNFOG, the organizers and the esteemed members for having us here with a panel from across the state. Now, we all know that anemia is a common topic, but its impact upon obstetrics is really massive and tremendous. So we need to focus upon it in every forum possible. And we all know that the incidence is 40 to 80% in India, and 40% of MMR is contributed by anemia, 20% being the direct cause and 20% being the indirect cause. And a woman, even with a mild grade of anemia, does carry the risk of mortality in labor. Therefore, anemia is a killer, of course, a preventable killer. And so the prevention is now our mission. Now, Madam, shall we start the panel? Dilshat, Madam, are you there?
Yeah. Can you hear me? Hello? Hello?
Madam?
Hello, can you hear me?
Yeah, we can hear you very well.
Yeah. Right. So, our panel members have been already introduced. So directly I will go with the questioning. And
the audio,
this panel,
audio
we
is
are
not
going
clear,
to concentrate.
is it not?
It provides a brief overview of the causes of anemia and what are the recommendations and what is the clinical management of anemia during pregnancy. So before proceeding with further, I asked Dr. Anuradha, what are all the physiological changes, though it has been already discussed. Physiological changes in cardiovascular system in pregnancy, and I want to stress on the physiological anemia, the definition, and what are the criteria for diagnosis. Dr. Anuradha. Hello. Dr. Anuradha. Hello.
Ma'am, we can hear you, ma'am.
Yeah. This is a question to Dr. Anuradha.
Anuradha, ma'am, can you please unmute yourself, ma'am?
Hello.
If not, ask somebody else to answer. She can answer later.
Yeah.
She's unable to get connected.
Yeah, in the case, Dr. Gomati. Dr. Gomati. And of course, the physiological anemia, everyone knows that there is an increase in the plasma volume, but there is a no concomitant increase in the RBC, resulting in physiological anemia.
Physiological changes in the physiological changes in anemia. There is increased RBC synthesis. There is decreased RBC synthesis. There are more than the plasma volume increases. So there will be the reduced RBCs, ma'am. So there will be a 10 to 15% disproportionate changes in the physiological changes. So that is the physiological changes, ma'am.
Yeah, the criteria for a diagnosis of physiological anemia. That
is the audio
has
clear,
been already
madam? I'm not able to follow actually.
Lower hemoglobin, lower RBC and PCB.
Madam, am I audible, madam?
Yes, madam.
Anu?
Yeah, yes, madam. I joined.
Yeah,
madam.
now, yes, you tell the criteria for physiological anemia.
Yeah. Blood volume increases by 42. Madam, audible, madam?
Yes, ma'am.
Hello?
Yeah.
Blood volume increases by 40. Yes, ma'am. Increases by 40 to 45%, and there is increase in plasma also by 50%. But total RBC increases by 20%, ma'am. This leads to hemodilution, and this starts in during first trimester and expands rapidly in second trimester to meet out the demand of enlarging uterus and vascular system, and protects fetus from impaired venous return and safeguards mother from the blood loss during delivery. This increase in erythrocyte volume by 18% is mainly due to increase in erythropoietin level. And physiological anemia in pregnancy is due to disproportionate increase between plasma volume, which is 40 to 45%, and red cell mass by 15 to 20%. And the hemoglobin should be at least 10 gram. RBC should be 3.2 million per cubic millimeter, and PCV 30%. And in peripheral smear, then the RBC should have normal morphology. Then we call it as physiological anemia of pregnancy.
So here we want to stress that in the peripheral smear, though the patient is in physiological anemia, the peripheral smear is normal.
Yes.
Next. Swami, can I go to the next question?
Yeah, Dr. Vairamala, are you there? Dr. Vairamala?
Yes, madam, I'm there.
Okay. Okay. So the next question, can we have the slide, please? The next slide. Okay, it's not, what actually, the previous one.
That's correct.
So for a clear idea, you need to tell us about the total iron requirement in pregnancy and why does the pregnant person need an increased demand of iron during pregnancy? Can you again tell us the details?
Yes, ma'am. The total iron requirement in pregnancy on an average would be around 1,000 to 1,100 milligram. The reasons for this increased demand of iron in pregnancy are the increased demands of iron, folic acid, and B12, and diminished intake due to poor diet or morning sickness. The disturbed metabolism, maybe due to pregnancy-induced depression of the bone marrow, infections in a country like malaria, asymptomatic bacteriuria, piles, and worm infestation. And if the pre-pregnant reserve is very low iron, they quickly turn to be anemic in the early trimester of pregnancy. And of course, the twin gestation. In India, the repeated pregnancies, if the birth spacing is less, that is also one of the predisposing factor during pregnancy. And that is faulty dietary habits has to be looked into. And the main requirements of anemia increased demand is due to the expansion of the maternal RBC mass, the need for fetal iron, and for the iron in placenta and cord, and of course, the blood loss that should be compensated during parturition. So we have to be pre-equipped with adequate iron stores and reserve during pregnancy.
Okay, fine. The next slide, please. So, Dr. Swati.
Yes, ma'am.
Can you proceed on with this? The causes of anemia in pregnancy?
The causes for anemia in pregnancy, we can classify it as acquired and inherited causes. The acquired causes being mainly the nutritional cause, which is mainly due to deficiency of your iron, folic acid deficiency, vitamin B12, or it could be protein deficiencies. The most common cause is usually a combined deficiency of the iron, folic acid, or the cause could be due to hemorrhagic causes, which could be acute or chronic. Acute in case of any APH, or chronic or during when they have a bleeding hemorrhoids, or it could be some bone marrow depressive disorders or bone marrow suppression such as aplastic anemia, or anemia due to chronic infections like malaria and tuberculosis, or anemia chronic renal disease or any other neoplasm. Inherited causes are mainly, as ma'am said, thalassemia, sickle cell hemoglobinopathies, and hereditary sclerocytosis.
Okay. The next slide, please.
Anemia, what we see the patient is a clinical anemia. But prior to that, the patient has, before the patient is presenting to you, even with the very early stages of anemia, like fatigability, initially there is a depletion of the store. Dr. Gomati, will you tell me the stages of iron deficiency anemia in pregnancy?
Hello, there are three stages of That is, the first stage is the stage of storage depletion. That is, it is the early functional iron deficiency, where the RBC indices as well as the hemoglobin synthesis is normal, but the storage form of iron, serum ferritin, is low. Okay, the second one is the iron deficient erythropoiesis. That is the synthesis of the RBCs are affected. So this can be monitored by the ferrokinetic studies, where in this the peripheral smear as well as the hemoglobin, blood hemoglobin levels will be normal. The third stage is the clinical iron deficiency anemia. Due to insufficient iron, there will be less hemoglobin in the periphery, causing clinical anemia. So these are the three stages of iron deficiency.
So in the second stage, what she told, this iron deficiency erythropoiesis, where ferritin level has come and the transferrin saturation has come down to say about 15%, and plasma iron also has come down, and hematocrit. So this is so we see only the clinical anemia. Prior to that itself, the patient started sinking into anemia. The next question, please.
Dr. Sujata, are you there?
Yes, I'm here.
Okay, okay.
So
Now,
am I audible?
Yeah, you're seen as well as audible. So we all know that in spite of anemia in pregnancy has been there for so many years, and we are trying to prevent the mortality and morbidity. We are still facing so much of challenges, and for that, we do find many anemia control programs in our modified strategies formed by the Ministry of Health and Family Welfare, ICMR. So many government programs are there, and so many specific strategies have been put forward. So, Dr. Sujata, can you tell us the prophylaxis which has been postulated by the government?
Yes, our
How
government
do we
has
prevent?
Our government has come a long way in this iron prevention program. It started long back. Suppose it is around the 1970s. It was introduced initially as a National Nutrition Anemia Prophylactic Program, where they gave 60 milligram of elemental iron. So after a long period, they found that it was not effective in preventing this iron deficiency. So they converted into a anemia control program, and they introduced 100 milligram of elemental iron with 500 microgram of folic acid. So that was the one which was being now recommended by our family welfare program also, because many studies have been undertaken. They say it is found that where the prevalence of anemia is high, like our South Asian countries, where the prevalence is high, more than 50%, we cannot go for the 60 milligram elemental iron even for prophylaxis. So it is ideal that we give 100 milligram of only where the prevalence is less than 20%. They go for other strategies, either a 60 milligram, and they even go for a 30 milligram. And some UK countries, they don't even give iron if her ferritin and all the levels are normal. But we are in the high prevalence stage. So it is ideal we follow our national family welfare program. That is, you give a prophylactic iron which contains 100 milligram of elemental iron and 500 microgram of folic acid starting from the 14th to 16th week of pregnancy. And it should be taken after delivery also for at least 100, that is 3 months. So this is the recommendation. But though WHO recommendation is 60 milligram for prophylaxis, and for treatment it is 120 milligram of iron, elemental iron. So, but in our situation, that is Asian countries, better we follow even for prophylaxis 100 milligram of elemental iron and 500 microgram of folic acid for prevention. And if she is deficient, go for 2 tablets. That is 1 tablet twice a day for minimum of 100 days. After correction also, you have to give for 3 months to correct the storage form of iron. And we have a lot of new programs also introduced, I think, which will we deal in the later questions.
So next slide, please. The prayer one, prior to that. The question prior to that. Yeah. So Dr. Teja, what are the spectrum of oronal preparation?
No,
what are the advantages over other?
Okay.
So Teja.
Yes, ma'am. I'm here.
Ma'am, no, the prayer slide. We want the prayer slide. One
Yes,
slide. This,
okay.
yeah.
Okay,
Yeah,
Shivagami.
yeah,
Okay.
yeah. This is the slide.
Yes, ma'am. Can you hear me, ma'am?
Yes.
Yes, ma'am. Oral iron preparations form the first line of therapy as it is inexpensive and less cost and easy to take. The iron-containing preparations that are available are vary widely in salt and its dosage and its chemical form. That includes ferrous and ferric forms of iron. Preparations that are available in the market are usually combined with folic acid. So there are various forms of bivalent components that come with iron preparation. Example, ferrous sulfate, ferrous fumarate, ferrous ascorbate, and ferrous gluconate. And ferric forms are ferric ammonium salt and iron tripolymaltose. So ferrous sulfate, which is commonly used in India because of its good bioavailability and tolerability, it contains 65 mg of elemental iron. Ferrous fumarate contains 100 mg of elemental iron, which comes as a 325 mg tablet. And ferrous gluconate has a lower amount of elemental iron, which is approximately 34 mg per tablet. So, as I already said, ferrous forms have better bioavailability compared to ferric forms, which is 3 to 4 times higher. As already Dr. Sujata ma'am discussed how much of oral iron has to be given as a prophylaxis and how much of oral iron has to be given as a therapeutic dose. But there are some recommendations how to give an iron tablet. It is best to be taken in an empty stomach, most commonly in early morning or after 2 hours after the food. Not to be taken along with the food because the absorption of iron is decreased by the phytates in the food. And factors that increase the absorption or orange juice or ascorbic acid increases, and the factors that decrease absorption are particularly tea. We should not take iron tablet with tea, antacids and proton pump inhibitors, and calcium. We usually prescribe iron and calcium together in pregnancy, but we should also ask the patient how they are taking the iron and calcium, whether they are taking it together or separately. And the education should be given accordingly. Then coming to the side effects, disadvantages of oral iron preparations, usually they have nausea, vomiting, flatulence, constipation, and reflux esophagitis. But advantages includes, as I said, it is easily available, easy to take, and low cost of the oral iron.
Next question, please.
Okay, the next slide, please. So the deworming schedule is not only for the endemic areas, but it should be given for any antenatal patient after the end of the first trimester. And Dr. Anuradha, can you describe the schedule?
Yes, ma'am. Actually, WHO advised deworming where worm infestation is more than 20%. Agriculture being the major breadwinning occupation in our country, so this is truly more than 20%. So barefooted walking, decreased sanitation, using farm tools with bare hands, fetching water from unhygienic area are the risk factors. Hookworm infestation leads to anemia, preterm labor, IUGR, extrauterine growth retardation, and early infant death also. So it's better we do a stool examination for ovaries, cyst, and occult blood in first visit. And how it causes anemia is hookworm, when it detaches from the intestine, it causes intraluminal microhemorrhage, which is around 0.2 ml per worm per day. It is really wondering, sometimes we lose 100 ml per day in heavy infection. Hence, deworming improves anemia. After first trimester, for hookworm infestation, single dose of albendazole, 400 milligram is enough. But in our country, along with the hookworm, we see a pinworm, Enterobius vermiculare is also very common. So we prefer to give 2 doses, 400 milligram, 2 weeks apart. And recent study shows deworming decreases 14% risk of dying during 4 weeks after birth. And also it prevents low birth weight.
Dr. Vairamala. Next question, please. Dr. Vairamala.
Dr. Vairamala, can you grade anemia? which is actually the CDC, WHO, ICMR, every organization, they have different categorization. So you can give us a summary of everything, the grading of anemia.
Yes, madam. According to WHO, hemoglobin level of 11 grams per deciliter, less than 11 grams is considered as anemia during pregnancy. In India, hemoglobin level less than 10 grams is considered as anemia by FOGC. The CDC, that is Center for Disease Control and Prevention, has defined anemia as less than 11 grams per deciliter in the first and third trimesters and less than 10.5 grams per deciliter in the second trimester. So the ICMR categorization of the grading of anemia is like mild is 10 to 10.9, moderate is 7 to 10 grams, severe is less than 7 grams, and very severe or decompensated, that is category 4, is less than 4 grams %, madam.
Once you have diagnosed, next
so
question,
overall, you need to have a hemoglobin level more than 10.5 in the second and third trimester. In the first trimester, it must be more than 11.
Yes, at least 11 in the first.
The next slide, please. First, yeah. Okay.
So once you have
now
diagnosed the condition, anemia, if we cannot simply give the iron preparation to correct the deficiency, so we have to calculate the iron requirement so that either we give suboptimum dose or we overload the iron. I asked Dr. Swati,
Yes.
how will you calculate iron requirement?
Ma'am, to calculate the iron requirement, the formula used is 2.4 into hemoglobin deficit in gram per deciliter into weight of the patient in kilogram plus 1000 milligram for this dose. Or if pounds are taken into consideration, then the formula used is 0.3 into weight in pounds into the hemoglobin deficit in percentage plus 500 milligram for the iron dose.
Now, we have calculated what is the dose that is required by the patient to correct the deficiency. That what are all the factors to be considered? Next question, please. What are the factors that has to be considered before treating anemia? Dr. Gomati. Dr. Gomati, please.
The factors.
Dr. Gomati.
Ma'am, the
Yes,
factors determining the treatment of anemia or the period of gestation, whether the patient is in first trimester or second trimester or third trimester, and the severity of the anemia, whether she is mild, moderate, or severe or very severe, and associated obstetric complication, whether she is having PAH or the cardiac symptoms or cardiac failure, she is in failure or not. So on medical comorbidities. So the period of gestation, severity of the anemia, as well as associated obstetric complications are the factors influencing the treatment.
Next slide, please.
Next slide, please.
Dr. Sujata.
Yes, ma'am.
Can you elaborate the symptoms of anemia?
Yes.
Yes.
So anemia is very common. So our PGs should know about all the common presentations. Usually the patient tell they have a sense of fatigue. So when they tell I'm not able to do anything, I have sense of fatigue, don't think they are malignary. So important, the earliest they say they complained of some fatigue, basic fatigability and weakness, tiredness, and they can have pedal edema. So when they have, usually our patients, they come with pedal edema, always rule out preeclampsia and next is anemia. So both are hand in glove. So you have to rule out anemia whenever they come with the pedal edema also. So as it progresses, they can have difficulty in breathing, some syncopal attacks, and they can have all the failure symptoms. So some can have some peculiar symptoms, like they say restless legs. That is, it's a funny sensation in the legs, in the lower limbs. Particularly it occurs when they take rest. And it may be a burning sense or a pulling sense or some funny tingling sensation. When she moves the leg, the symptom immediately disappears. So what she will be doing now, just like that, she will be moving her limbs on and off. So that's a typical of iron deficiency. Though it can occur in many other conditions, the restless legs, it is classical. It can occur in an iron deficiency, and it is due to the iron deficiency which causes the enzymes, which iron dependent enzymes in the neurons, and it also affects all the reduction of iron containing enzymes in the epithelium and the gastrointestinal tract. So she can have typically symptoms, all this like pica. So pica, a craving for the non-food items. So it may be a pagophagia, that is intense craving to eat ice. But we all eat ice creams. Now we are afraid. We are suffering from anemia. We don't know. So we can have a pagophagia, or she can have a geophagia, that is eating that soil, all those things, or amylophagia, that is intense craving to eat starch. That is, she'll be taking rice, raw rice. So such symptoms are also, they are very common. So if you take the signs, she can have an alopecia and dry mouth. These are all some certain different symptoms. So always you try to elicit all these things, and you try to elicit the pallor. You look for the conjunctiva, pallor, eyelids, tongue, and nail beds, palm and soles. You look for, don't just examine the tongue alone. You look for all the sites to look for the pallor. And also, you can also see the signs like koilonychia, and tongue will be smooth and atrophic with the stomatitis and cheilitis. So you look for all those things. Suppose she's having a severe iron deficiency, you will have no difficulty. There will be edema, JVP will be elevated. So all this will be happening. And typically, she can have symptoms of that Plummer-Wilson syndrome also. So difficulty in the swallowing. And these are all chronic anemia. Our patients have suffered from chronic anemia also. So you also look for other nutritional disorders, and this chronic anemia due to atrophic glossitis and also gastric epithelium becomes atrophied, and she can have all these symptoms. So always from head to foot, we tell no, from head to foot you examine and ask for symptoms also from head to foot. It will be very, they may have some subtle symptoms in the earliest stage. So don't miss those features.
Next slide, please.
Yeah, she has rightly pointed out the rare symptoms, because we usually will miss and we attribute the symptoms to some other thing, some other mineral deficiencies, magnesium deficiency, so on. So it's a very important thing that you should look into the anemic status, even though she has some different unusual symptoms. The next slide, okay.
Teja, here is a patient who is coming to the OPD.
Yes, ma'am.
She's a 21 years old primary, married since 1 year, weighing 45 kg, from low socioeconomic status. Her pregnancy is 16 weeks. She complains of easy fatigability, giddiness, exhaustion now and then when she is doing her daily activities. On examination, the patient is anemic. Her hemoglobin is 8 grams. How will you approach this patient?
Okay.
Teja?
First, yes, ma'am. Yes, ma'am. Can you see me, ma'am?
Yeah.
Okay. Here, this patient is young, and we can see that from the history, she is from low socioeconomic status, which means that her nutrition is not adequate for iron-rich diet. So I would recommend her first regarding nutrition, and she has to take iron-rich diet, which includes green leafy vegetables, red meat, liver, fish, jaggery, and lentils. And iron fortified food also can be taken, like cereals and tofu. And the second thing I would ask her is whether she was already dewormed. If not, then I would go for deworming her. And because she is only 16 weeks and her hemoglobin is 8 grams, she falls into moderate anemia according to ICMR grading type of system. So since she is in 16 weeks, we still have time for oral iron and to build up her hemoglobin. So I would, according to WHO, she needs 120 mg of elemental iron with 400 micrograms of folic acid every day. until her anemia is corrected. And once it's corrected, once she reaches 11 grams of hemoglobin, then I would change her to prophylactic iron dose, which is 60 mg of elemental iron with 400 micrograms of folic acid. And I would ask her to come back after 3 weeks just to check her compliance and then see is hemoglobin improving or not.
So this is the patient. So we have taken two factors, that is the gestational age and the degree of anemia. So this type of patient warrants oral iron. Next question, please.
Next slide, please. Is it seen? Okay, Dr. Anuradha.
Yes, ma'am.
Now you can tell us about the assessment of response to oral iron, because the assessment is very important. By that, we'll know whether the patient is a compliant patient, whether the patient is able to tolerate iron, or in spite of taking the iron properly, regularly, if she is not responding, that means we have to think in terms of refractory anemia, find out further causes. So assessment of the response is very important. And how do you look for it?
Subjectively, the patient will have improvement in fatigability, a sense of well-being, her appetite will increase, and her outlook itself will be good looking, ma'am. And her dyspnea also would have improved. And hematologically, what we are supposed to do is we have to see for reticulocytosis, which starts from 7 to 10 days of starting treatment. And there will be increase in hemoglobin, increase in hematocrit, and we expect increase after 3 weeks of starting oral iron therapy. And it increases by 0.7 grams per deciliter per week, ma'am. That's the thing we expect that type of increase. 0.7 to 1 gram.
We move on to the next slide. Next slide, please.
Next slide, please. So, Dr. Sujata, can I read it? So she the second
slide not visible, madam.
Yeah, we cannot see the slides.
Slide not shared, madam.
Is it seen for me? It is not seen anyway. I'll read it.
Madam, it's not seen for us, but I think we can go ahead with the discussion of the panel. Yes, even if the slides are not there, we'll go ahead.
She is gravida 3, para 1, live 1, 22-year-old, 48 kg, weighing 48 kg. The last childbirth is 1 year and 4 months, and the present pregnancy is 26 to 28 weeks by gestational age. Now she has come with a history of palpitation, breathlessness on exertion, restless legs at night, and she gives history of nausea and vomiting on taking the iron tablets. So definitely she is not tolerant for iron tablets. And on examination, pallor, stomatitis, atrophic glossitis is there. Now, how will you evaluate, and what is your diagnosis, Sujata, and how do you proceed on with the management? Now that she is not tolerant to oral iron.
Again, she is
this is the
not tolerant to oral iron, and she is having symptoms.
Yeah. Yes.
And she is
the
also
next slide.
26 to 28 weeks of 26 to 28 weeks, and she is also symptomatic. She is having palpitation, breathlessness. So I would like to assess her hemoglobin level, and most probably it looks like a nutritional anemia only. So anyhow, I would evaluate, and according to her hemoglobin level, I would like to decide, because if she is symptomatic and the hemoglobin is less than 7, I would like for a Paxil transfusion. Or if it is more than 7, I would also like to go for a parenteral line. So that depends on the symptoms and the hemoglobin level also.
Yeah, now Sujata, you can take it as the hemoglobin is 7.6.
She
is only 26
to
28
is 8.8 or 8.6, 8.6, 8.4, somewhere between 8 to 9.
Okay. So then I would like to go for only a parenteral line. So I would already our panelists discussed how to calculate the iron dose, everything. So I would like to go for a parenteral line. So calculate the dose and then preferable is an iron sucrose. So nowadays we go only for an iron sucrose IV preparation, and the ideal will be 100 milligram in 100 ml saline, and to once in every 3 days. It should be given over 10 to 15 minutes. And you have to get a consent. You have to keep the emergency tray ready, and then you start a oral IV iron preparation. And it is important that when you prepare that oral iron sucrose, IV iron sucrose, it should be 100 milligram for 100 ml saline. So don't go for 200 ml or don't increase the dose, because, and don't transfuse over a longer time also, because they say that the free oxide radicals will be liberated. So that may cause some harm also. So always you decide, you calculate the dose and start the preparation and start the dose. So ideal will be 100 milligram, but now a lot of recommendations have come. So you can go for 200 milligram also in 100 ml NS, and you can give on alternate days. They say not in once in 3 days. You can, so lot of studies are going on. So 200 ml in 100 ml NS, you can give it on alternate days. Or but now what they say, this no side effects is we give is 100 milligram in 100 ml saline once in 3 days, which has been very much approved. And this sucrose, no, there is almost nil side effect. So if you give in this dosage, almost nil side effect, but all the other dosages will get near, they are nearing up to approval. So 200 milligram also can be given in 100 ml saline on alternate days, because the iron sucrose molecule, the molecular weight is very low. So you have no any anaphylaxis, almost nil. They have very rarely reported any anaphylaxis reaction. Very minor reactions we can get: pain, a burning sensation in the site of injection, some nauseating feeling, some metallic taste in the mouth. So like that, few side effects you can get. Otherwise, it is a very safer drug. And other iron preparations, they have under trial also, ferric gluconate, citrate and all. But those are having very much a lot of side effects. And now as such, gluconate, ferric gluconate is there. But as far as pregnant women, the approved drug better will be an iron sucrose, and you can adjust the dosage according to your availability and your basic facilities available. So,
and it should not be combined with oral iron.
Yes. It's very important.
Yeah, because to avoid toxicity. Okay.
Toxicity, yes. Very important.
Okay.
So for completion, that parental preparation, we should not forget what we used previously. That iron dextran complex and iron sorbitol citric acid. All these things have been given intramuscularly. I think that somebody even there practicing. Then second point I want to stress is the practical point. When you are giving iron sucrose, you should be very definite that the cannula is inside the vein. Even if a small quantity of the iron sucrose comes out, it creates marked reaction locally. Third one, the total dose of iron sucrose per week should not exceed 600 milligram. Now, I asked Dr. Vairamala that iron sucrose we have to give, if at all, 600 milligram per week. What are the iron recent parental preparations, and what are the advantages of these over iron sucrose?
Now we have a novel parental iron formulation, which is dextran free, which contains iron 3 hydroxide, which is complexed with the carbohydrate molecule. So this prevents release of free iron from the molecule that can cause oxidative damage to the body tissues. This iron complex acts like the physiological carrier of iron in our body, ferritin. So these complexes deliver iron to the physiological transport system at neutral pH. So as a type 1 complex, FCM delivers iron gradually, mainly to the reticuloendothelial system of the liver. So this targeted and slow release accounts for the low toxicity and a wider safety margin. And weekly dose, and which allows a maximum weekly dose of about 1000 milligram per week. Because of these factors and because of neutral pH and physiological osmolarity of the FCM formulation, high doses can be administered with good tolerance and less side effects. And toxicity is very unlikely to occur during the clinical use of FCM. And as it does not contain dextran or its derivative, it is not likely to cause dextran-induced anaphylactic reaction. And with together with its very low potential for immunogenicity, there's an excellent safety profile and convenience for both patients and the medical professionals, because of the lesser number of hospital visits, avoidance of multiple pricks, and logistics. And this ability to give large doses in a single session will also enhance the cost effectiveness of the iron replacement therapy. We generally administer, depending on the iron calculation required for the patient. Generally, parenteral iron preparations are given for mild and moderate anemia. Per sitting, maximum dose would be 1000 milligram, diluted in 200 ml of 0.9% normal saline, and administered as an IV infusion over 15 to 20 minutes. But cost-wise, the 500 milligram of FCM costs around 2,500 to 2,800 rupees per vial, and double the dose when it is 1000 milligram.
Madam, you are giving it for antenatal cases or postpartum only?
No, I do give for the second trimester and third trimester patients, madam. Also in the pure period.
Yeah, the trials are now available. They say that it is safe in second and third as well, also in postpartum. Yeah, it is very effective, but the only thing is the affordability. It is on the higher side, but definitely it is more effective, and the rise in hemoglobin is phenomenal.
Yes.
Yeah.
Is it US FDA approved, madam, for pregnant women? Or only for postpartum as such, as on now?
No. It is CD. I saw that it is the approval is there for.
There have been many trials and journals which have studied this safety profile for FCM in second and third trimester of pregnancy and found to be safe.
No, the latest edition of iron does not even gives the details. FCM is approved and used in pregnancy in the second and third trimester.
Yes, ma'am. First trimester alone,
it is. It is not. Yeah. Second and third, it is approved.
Yes.
Textbooks even have documented it. Okay.
One more thing I wanted to stress is iron sucrose should not be given during the first trimester. Usually, we have to give from second trimester only.
Second trimester only.
So let us move on to the third case.
Okay.
Next
Now
slide,
this is for Dr. Swati. The final scenario: 26-year-old multi-gravida, gravida 3, para 2, live 2, with the previous 2 normal vaginal delivery, with the 2 previous female children. So she hasn't gone to the hospital regularly. She is a defaulter of antenatal visits. Now she has landed up at 34 weeks with a facial puffiness, pedal edema, dyspnea on daily routine work, palpitation, pallor. Hemoglobin is 6.8 grams per deciliter with a tachycardia 108 per minute with a BP 110/70. Now she falls now under in the severe category. How do you proceed? How do you evaluate, Dr. Swati?
Ma'am, she's a multi-gravida presenting with features of severe anemia as her hemoglobin is less than 6.8. So the immediate thing is you'll have to admit the patient and then evaluate her. So initial admission and evaluation for the mother of the vitals, and you'll have to rule out if she has features of failure. You'll have to rule out if she has failure or not, then assess the fetal well-being and send for, because she has not gone for prior antenatal visits, do basic investigations, assess her blood grouping and typing, and give her a packed cell transfusion, probably in an ICU setup with continuous vitals monitoring. So you'll have to give her a packed cell transfusion, any irrespective of the gestational age. So with severe anemia, it's going to be only packed cell transfusion. If there are features of failure, then you'll have to concurrently treat the failure and administer packed cell transfusion in a very cautious manner and very slowly. So after giving, depending on her hemoglobin level, we have to repeat the transfusions in 24 to 48 hours until we reach the target level. And then we'll have to advise her on her diet, iron-rich diet, and then iron supplements, that is therapeutic iron supplements, has to be followed.
So once the 1 unit of packed cell transfusion given, it increases the hemoglobin by 1 gram per deciliter, and the defect is seen after 24 to 48 hours. That's why we have to repeat on the third day, and if necessary, we can repeat the packed cell transfusion. So Anu, can you highlight the indications for packed cell transfusion in anemia during pregnancy?
Yeah, it varies from various gestational weeks, ma'am. During antenatal period, if the pregnancy is less than 34 weeks, hemoglobin.
The slide next slide.
Hemoglobin is less than 6 grams, with or without signs of cardiac failure, hypoxia, or when there is impending heart failure with hemoglobin 5 to 7 grams, we can transfuse blood. And if the pregnancy is more than 34 weeks, if the hemoglobin is less than 7 grams, without signs also, you have to give Paxil transfusion. And in severe anemia with decompensation. And when the anemia is due to hemoglobinopathies or bone marrow failure syndromes, after consulting hematologist, we have to transfuse blood. And in case of acute hemorrhage, APH, if the hemoglobin is less than 6 grams per deciliter, depending on the hemodynamic condition, we can transfuse blood and other products. And during labor, when the patient comes with hemoglobin less than 7 grams per deciliter, we have to decide and transfuse blood and other products. And during postpartum period, the patient might come with anemia, shock, or hemorrhage with signs of hemodynamic instability. And when the hemoglobin is less than 7 grams, even during postpartum period, we can transfuse blood after taking proper medical history and other symptoms.
So when the patient, I wanted to stress, if the patient comes with severe anemia to say about 5 to 6 grams, at what WHO or whatever it is, the ICMR has given the guideline, where the anemia is very severe to say about 5 to 6 grams, irrespective of the trimester. We see that the factors which are governing are the gestational age and severity of anemia. But when the patient is severely anemic, the two we have diagnosed, it is going to be only iron deficiency. In that case, we can transfuse PAC cells in the first time. So it is when there is a severe anemia, the transfusion, PAC cell transfusion, to be given at any time. Now let us move on to the other nutritional anemia. What are the other nutritional deficiency anemia? I would like Dr. Gomati to highlight the megaloblastic anemia and its impact on pregnancy.
Megaloblastic anemia is due to folic acid deficiency and B12 deficiency. Folic acid deficiency, that is called pernicious anemia of pregnancy, because the B12 has a long storage and normal absorption in the pregnancy. So the essential of the folic acid is, essential for nucleic acid synthesis, that is conversion of uridine to thymidine in DNA synthesis. So when the RBC synthesis happens, the bone marrow hyperplasia will be there. The increased RBC need, when there is a folate deficiency, there will be megaloblastic erythropoiesis in our blood. So why there is a folic acid deficiency is because of deficient supply from the food, or there is reduced intake because of hyperemesis, or there might be decreased absorption because of any intestinal problems. And nowadays, because the girls also have smoking and social alcohol drinking, there will be decreased availability of the folic acid. So normally the rich green leafy vegetables are rich in folic acid, but the 90% of the folic acid is lost in cooking. Okay, so the normal dietary folate levels, that is the RDA, is 300 to 400 micrograms per day is needed in the pregnancy. So when there is a folic acid deficiency, the patient will not present in the first trimester. They'll present in the late second and third trimester. That is, they can present as a case of anemia who are failure to responding to the oral iron therapy. So they might have anorexia, they might have vomiting, they might have atrophic glossitis, and to the extreme cases, they might have mild hepatosplenomegaly or congestive cardiac failure also. So how will you identify? Doing a peripheral smear is the diagnosis. So the peripheral smear will show the oval macrocytes, hypersegmented, more than 5 lobes, neutrophils. The MCV will be more than 90 cubic micrometers. And then on seeing this, we can go for serum folate levels and serum B12 levels. If it is very less, then we can correct the folate deficiencies. So the obstetric outcome of the folate deficiency will be the patient can have abortions or neural tube defects, prematurity, as well as antepartum hemorrhage. So when the patient has already suffered, we can go for a therapeutic dose of 5 milligram of folate treatment in pregnancy.
Okay, next slide, please. Dr. Tejavati, in spite of the proper treatment, according to the protocols, if the patient is not responding, then she falls under refractory anemia. So how do you evaluate?
If anemia, if after giving oral and parenteral iron, if the patient is not responding, we call it as refractory anemia. So you have to think of other causes of why she is not responding, like CKD, chronic kidney disease, where there is a deficiency of erythropoietin hormone, which stimulates the bone marrow to produce RBCs and other cell lineage, and aplastic anemia and other chronic diseases. So in this case, I would like to evaluate further with baseline investigations and special investigations, baseline including CBC, peripheral smear, reticulocyte count, and all the iron parameters like iron TIBC and serum ferritin with vitamin B12 and folic acid, and stool for overcyst. And last would be the bone marrow to look at pancytopenia for aplastic anemia. So if the patient is not responding with iron therapy, then we have to go for a recombinant human erythropoietin hormone injection, which can be given 50 to 100 units per week. So safety has been confirmed in pregnancy and in postpartum, and because of its large molecular weight, it doesn't cross the placental barrier. So it's safe in pregnancy for end-stage renal disease and the CKD patients.
So we should not forget dimorphic anemia. The patient can have iron deficiency and megaloblastic anemia. In this, the blood picture is very clear. The peripheral smear is the one which tells us whether it is iron deficiency pure or it is a megaloblastic. In dimorphic anemia, you will have a macrocytic and hypochromic anemia.
Yes, ma'am.
So with this, I hope that we have covered most of the parts of nutritional anemia. And I would also thank Dr. Revati Janagiraman, my friend, and Dr. Sambat Mari, my colleague, for giving me this opportunity in this platform.
So let me conclude a few points to summarize. Early detection of even mild form of anemia is important. That is when the transition occurs from the physiological to pathological state. That is where we have to pick up the patients, identify anemia, give them the nutritional advices, and evaluation. The most important point is not by hemoglobin alone. Complete blood count, peripheral smear, RBC indices are mandatory. The third point is I would like to stress is identify the type of anemia and the cause behind it and the associated comorbidities, so that the treatment can be effective, can be individualized and made compliant to the patient, taking into the consideration of the two important factors, the severity of anemia and the gestational age of the pregnancy. So with this, we should provide the women of our nation the ability to withstand and survive the blood loss during parturition. So the Ministry of Health and Family Welfare says a simple increase in 1 gram of hemoglobin per deciliter will be able to reduce MMR by 20%. So let us all work in unison and make the mission of anemia prevention possible. Thank you.
Madam, I would like to thank our Madam, Sivagami Madam, Dilshit Madam, Revati Madam, Sampath Kumari Madam. This was very nice. And our Shanti Gunasingh Madam's presentation, all were very nice. Thank you all panelists. Madam, anybody having experience on exchange transmission? Nobody mentioned. Here, one of the examiner was telling he was practicing in Karnataka, their hospitals. Anybody following?
No, we are not following.
No.
No. Early 90 we had.
Long back.
Long ago. After that, no.
70s and 80s.
19,
But
madam. I was
he
an
was
assistant
still
in
they were
19,
following it since for failure
1992
cases.
and all that. It was there in IOG. After that, blood bank medical officer will come and give Pramila, madam. After that, it's
Very,
Thank you,
very
madam.
well
Thank
done, Dr. Sivakami and Dr. Dilshat.
Thank you, madam.
Congratulations. And I also appreciate the wonderful job done by all the panelists. Very useful, practical points you have brought out. Congratulations.
Thank you, madam. Thank you for the opportunity. Everybody got benefited, and we learned actually new concepts like restless leg syndrome. Especially, it was very catchy because we all were thinking that it was because of micronutrient. Yeah.
I gave a talk on this in last IMSCOM. I gave a talk on restless
in
leg syndrome.
menopause, but we didn't know that it is even common in pregnancy, anemia in pregnancy. Yeah. And FCM also we learned a lot. And Madam Shanti Madam, crystal clear description of thalassemias. Really, it was useful, madam. Thank you so much.
Very, very crisp and clear.
Yeah.
Thank you, panelists, and thank you, moderators.
They are very much active.
Such a wonderful
Enthusiastically, they were participating, madam. All my panel members, they are very much cooperative, very much interested, very much enthusiastic. I met a group of people through your platform, madam. Thank you, madam.
Yeah. Thank you, ma'am. Thank you, ma'am.
Thank you. Bye.
Thank you, ma'am. So we still have a few more quiz questions. So please, I want you to stay back. And after the vote of thanks, we have the quiz results. So I hope everybody stays back to know who are the winners. So let us have the last set of quiz questions. So can we have the questions, please? Severe anemia is defined as less than 10 grams, less than 7 grams, less than 4 grams, less than 5 grams. No clues from the faculties. It's only for the delegates. Radha Madhavi, madam, no clues. We want the delegates to participate. So come on, guys. Like the panel was like so enlightening and they were discussing this in detail. So I'm just looking forward for all right answers. Fastest finger wins the prize.
10 seconds more.
Yes.
44% answered.
Good. So we still have a good group of audience who are awake. So congratulations to the whole team that we are kept the audience awake so that they can participate in the quiz. Thank you, team.
Time up, ma'am.
Yes. And I think we have one more question, is it? Or is that it, Chitra?
One more question.
Yes, the last question. Which type of anemia you need the retinal screen? This was discussed in the discussion today. I hope we have attentive audience who can pick up iron deficiency anemia, sickle cell, thalassemia, megaloblastic anemia. Which type of anemia you need to do the retinal screening?
Iron deficiency. Iron deficiency.
We will confuse you giving easy choices. Don't trust us. Okay, so Chitrakala, are we done?
Time up, ma'am.
Yes. So kindly please stay after the vote of thanks and we will have the quiz results. So I want you to know the quiz results and then we will call it a day. It's an honor for me to invite Dr. Radha Madhavi. Madam, can we have Madam CV, please? Chitra, yeah. Madam is the founder, president, Tiruvannamalai OG Society, director of Rajam Institute of Multispeciality Hospital and Paramedical Sciences. She is a joint secretary and executive committee member in TNFOG. She's a member of many societies. Madam has done her MD from the Air Force. Proud of you, madam. The Ponniyin Selvan, we don't forget you for that. So madam was the Ponniyin Selvan of TNFOG conference. We cannot forget her in that. And madam has been a practicing gynecologist in '94 and her field of interest is rural health. So madam, over to you for the vote of thanks.
Good evening, seniors and friends. It is a great pleasure and privilege for me to propose the vote of thanks for this TNFOG Marathon CME on anemia, the most important cause
in our part of the world for maternal and fetal mortality and morbidity. At the outset, I like to thank the office bearers who are the doyens in academics. The office bearers of TNFOG, Revati Madam, Sampath Madam, Vijay Lakshmi Gnanasegaran Madam. I thank our chief guest, Dr. Alka Kriplani, who in spite of her busy schedule gave such inspiring words and advice towards eradicating anemia and saving mothers. It's wonderful day that our e-newsletter was released. Great academics and encouragement to postgraduates and practicing obstetricians. The time of the CME is to encourage all obstetricians to log in so that the time 4:30 to 6, it does not disturb their routine work. I thank our esteemed judges, Dr. Nidhi and Dr. Vijay Lakshmi, who are ideal for their job and an inspiration by themselves. I congratulate Dr. Krishna Parvati and Dr. Selvarani for their clear basics and presentation and nice slides. The slides are very useful actually. I thank Dr. Ramani Devi and Dr. Shanti Gunasingh. What to tell about them? They are a class apart and their enthusiasm and joy is very infectious. And I thank moderators Dr. Sivagami and Dr. Dilshad who made us forget what time it is in the evening today. I thank our dear panelists for making this session so profound and thought-provoking. Dr. Sujata, Dr. Anuradha, Dr. Gomati, Dr. Swati, Dr. Tejavati, and Dr. Vairamala. Last but not the least, dear Dr. Priya, for conducting the CME in a smooth way. Thank you, Sheel, from the bottom of my heart, from TNFOG for helping us bring out such good academics. We should eradicate mortality from anemia, and as all of you promoted, ferric carboxymaltose is definitely a boon to us in the newer generation. Thank you all so much. Good evening and good night. Thank you.
Thank you, madam. Thank you. That was so nice and elaborate. So, Chitrakala, can we have the quiz results, the much awaited results? So, for the session 1, the quiz winner is Dr. Soumya Ravi from Trichy Society. Congratulations. The session 2 is Dr. Angeline Emmanuel from Chennai. She is one of the students or postgraduate of SRMC. Proud of you. And the third session, we have our winner, Dr. Radhika Gauri from Tirunelveli. Excellent. Congratulations to all the winners and thank you for participating. Proud of you guys.
Congratulations.
So, yes. So, shall we call it a day, madam?
Yes,
Revati, madam,
yes,
you want
yes,
to
yes.
say?
Yeah. It was really wonderful. I'm happy that nearly 50 members still stayed back.
Yes,
till
all
the
of them
end.
stayed, madam. Nobody
That's
left.
really nice.
Till even the vote of thanks people stayed back.
Yeah,
Very
exactly.
nice.
Yeah, exactly. Very interesting and very useful. Thank you.
Thank you, madam. Thank you.
Thank you,
Shanti,
everybody,
madam.
man. Thank you, man.
Bye.
Thank you, madam. Thank you.
Thank you, ma'am.